Welcome to North Idaho Experience. In today's episode, we sit down with Dr. Chris Meadows to talk about stem cells. He is one of the owners of Clinic 5C. He's certified in physical medicine and rehab, also regenerative medicine specialist. So what does that mean? That means we're going to talk about stem cells. We're going to talk about what they are, how they're used, and the future of stem cells as well. We also dive into peptides, supplements, and optimizing your morning routine. You guys are going to love this conversation, especially if you nerd out on health optimization. Check it out.
Remember that we have a podcast?
No, I was tracking you. Don't worry. That saves me. I need to track Eric so I can know when he's actually coming.
Yeah, we don't want to know where Eric's been.
Well, yeah, there's that, but it's nice. So we track each other on Life 360. Our families track each other. I can see where his kids are, and it's actually kind of nice.
Keep tabs.
It's kind of nice.
It's pretty funny.
Got to know where each other's at sometimes.
Yeah, like today, I would have been stressing out. I would have been like, "Where's Dave?" But I looked, and I'm like, "Oh, he's on his way."
We're good.
Yeah, it's fashionably late.
Let's do it.
Dude, I have so many questions about stem cells. So I definitely want to get into that deeply. And the cool thing is that Dave went and did a consultation with you. Yep. So we could talk about that at length, which is neat.
I was interested about the consultation because I never know, like going to a doctor for anything is just, you have no idea. They're going to poke me. They're going to prod me. Like, what is this process? What is it going to come out? The fact that we just went in there and it was really kind of like somewhat of a physical, and then going in and doing the ultrasound, which was great because I'm looking at it going, oh, and it was neat to see all the.
What area specifically were we talking about?
I was looking at my shoulder just because I have just shoulder pain. I feel like I feel like a little bit of a bitch because I come out of there and I'm like, I know this guy's more messed up than me. We should have sent you. You look like just a mess. I'm certain.
Yeah, that's just my face though. I don't know if that's fixable with stem cells.
I'm very happy to be.
We do regenerative cosmetics as well. It's not limited to musculoskeletal.
We'll talk about that too because my wife's mad because my eyelids, I've been punched in the face so many times. My eyelids, I think, are starting to droop down where I can't see anymore.
You'll have to see my partner.
Bulldog, yeah.
You know what's neat too is I actually thought about it when I left because I told my wife, I'm like, I'm very happy to be pretty healthy. Mm-hmm. After my careers and everything else and not really have any major injuries. But, I thought about more stem cells and like the little things that you were finding that were wrong is I like the fact that to know that it doesn't matter even if it's small injuries, actually I can probably recover from those really well and get myself back into a better spot and prevent anything further or getting more damage.
Yeah, there's a few different ways to approach that, which is certainly if there's something bothering you, then you want to figure out what's going on and try to reverse that, make yourself functional and highly functional or we talked about the limitations you have in the gym and the inability to do certain exercises or certain movements. And that's one aspect, but also there's a preventative component as well where you talk about, I had this injury several years ago, or maybe we find something on ultrasound and then we start to be proactive. And that's a certain mentality that some people have to try to be proactive in their care, and particularly people that beat up their bodies, in the past. I'm a former football player, and so I've had my share of injuries. And so I'm constantly thinking about, what do I need to watch out for? How can I be preventative so that I don't go into or have future problems and start to develop knee pain or back pain? And so how can I be preventative in that space? And so that's another component of regenerative medicine.
Right. What does that look like? Does that look like not lifting so heavy in the gym or things of that nature?
It could be. I wouldn't say not lifting as heavy, but I think it would be more, when I think about it, it's more area specific training, right? And thinking about some of the common injuries. When I think about general health, particularly for myself, I'm thinking about what are some of the most common injuries that we see, right? Shoulders, very common. Low back, very common. Knee problems, very common. So how do we approach those areas from an exercise standpoint to support those joints, support the tendons, particularly the tendons that surround and the ligaments that surround them, to increase or enhance their structure and their function? And that starts with exercise. And then it goes into, of course, the bigger picture of lifestyle and what we're doing from a diet standpoint. What's our recovery look like? What's the supplement protocol that we're doing? And then it can also be procedural. So it's kind of full spectrum in that front. And it just depends on how aggressive patients want to approach it.
Mm-hmm. But it sounds like you'll always try prior to surgery all of the other options. Is that generally the best case?
Correct. Yeah. So I'm a non-surgical orthopedic specialist, and so I'm not doing any surgery. And most of the patients that come to me have either had a surgery in the past that maybe wasn't successful, and so they're hoping to prevent surgery, or are in this gray space where they're not necessarily a great surgical candidate, or the disease process isn't far along enough where they are being considered for surgery, but there aren't many options in this kind of middle ground, right? There's the steroid option, and we can talk about what that looks like. And some people have tried that and they've said, gosh, this just hasn't been effective. Maybe it's been short-term relief, or maybe you've exceeded the maximal number of steroid injections that is recommended because of the potential negative consequences from steroid injection. And so patients are oftentimes left in this like middle area of, I'm not a surgical candidate, or I don't want to have surgery. I've exhausted steroid injections, or I don't want to have a steroid injection. And historically, there's not been great options or treatment modalities for this space. Exercise therapy is a great option in that space, but can be ineffective as well. But now we're in a space where we have these regenerative tools that can be effective to not only be an alternative to steroid, but also prevent surgery.
It seems like there's a lot of people I talk to that have surgery, especially in the fire service. We have tons of guys getting back injuries, right? And people joke about it, but getting in and out of a rig all day long, like that impact, right? And then carrying stuff, and obviously law enforcement, a lot of back injuries just from having the weight on the hips and everything else all day. But a lot of those guys end up with surgeries, and then I so commonly, even in today's state of medicine, see those things, they fail. People get their backs operated on, shoulders operated on, and they're just never the same. Yeah. And it seems like we, way back in the day, it seems like we kind of relied on like God's medicine, right? And trying to figure out how our bodies could fix themselves. Mm-hmm. Then we started relying on modern medicine in the sense that, well, just get in there, cut it open, fix it. And now it seems like we're starting to trend back to like, what options do we have to let the body fix itself? Right?
Yeah. The pendulum's always swinging, sometimes swings a little bit too far. And that just comes with advancements with medicine. We're starting to understand the human physiology better, and we're starting to understand what the body is trying to do to support itself. And medicine has historically been what medications, what pharmaceuticals, what surgical interventions are available to augment such that we can, create new structure or manipulate the surrounding in a manner that we think is going to be most beneficial. And as we've had more knowledge, as we've gained more knowledge in this space, we're seeing, okay, this is what the body is trying to do. Here's the response that the body is, developing. How can we, and sometimes you just stumble upon this, when we actually help the body do those things, you get better outcomes rather than us coming from an external environment and saying, I'm going to manipulate this, I'm going to do this, I'm going to change the structure, put a rod in, create something new. And really what we're starting to understand better is that we can, when we support the body's natural processes for healing, we can actually allow for really great, really successful outcomes.
Well, yeah, you see, bodies respond, even when you do surgery, it's not that you're immediately fixed. Your body has to respond to new materials inside of it, all that stuff. You see it in, women right now with breast implants, right? You're seeing a lot of those get rejected by the body, right? Yep. So putting stuff into your body just doesn't seem like, I feel like people have the understanding that like, I'm going to go get surgery and it's all done. But like you said, just allowing the body's going to have to take that in. Yeah. Whatever's been done with it, it's going to have to create a new environment for it.
Yeah. And again, it's just a different mindset of how we're approaching medicine and how we're approaching healing. And we're seeing that structures that we've historically thought are unable or unsuccessful at healing themselves, we're actually recognizing that if we can take advantage of certain molecular processes or physiologic responses that the body is attempting to do, we can actually see great outcomes in a non-surgical manner. So it's really changing the game of medicine and particularly musculoskeletal medicine and recovery.
That's cool. I had a hernia surgery and I have a hernia mesh in, and I hate the thought of it in there with scar tissue all around it. Yeah. So I wonder if at this point, is that something that I could have done a different way to heal that, or in the future, is that going to be an option?
Yeah, hernias is one of, again, when I kind of look at injury prevention, hernias is one of those, very common. Actually, my dad just had the same surgery just like 2-3 weeks ago. And it's, again, very common because you have structural tissue that weakens over time. And so then abdominal contents, or where the hernia is located, starts to outpouch. And so that's something that I'm thinking about from a preventative standpoint of, here's a tendon or here's a ligament structure that we want to be proactive in supporting its structure and healing. And so there's some exercises and maneuvers that you can do to maximize how the pressure in your abdominal, your abdominal wall is, not going towards defective areas and actually refortifying that. So from a preventive standpoint, there's not a procedural approach per se, and I actually haven't seen anything from the regenerative procedural side to go after that. Meshes are, certainly a great option, and it's kind of the standard of care. Sometimes people will do some regenerative properties in addition to the surgery, so that would not be uncommon as well. But I haven't seen any data out there from a regenerative approach for specifically hernias. So
it's probably not the biggest target out there, right? I imagine it's best used in joints, things like that.
Correct, and that's like 90% of what I'm doing.
Right?
Yeah, joints, tendons, ligament areas. That's a majority of what I'm doing. Yeah.
So talk us through. I was under the impression that so you're using stem cells.
Correct.
Is that recent that they've been allowed in the U.S.? I was under the impression you weren't allowed to do stem cells in the U.S. Am I crazy?
Yeah, it's a challenging environment, and it's a lot of I don't know if misinformation is the right word, but there's just a lot of unknown, lack of education, if you will. And that's because the environment is very complex and there's nuances here. But what I would say is that the most common question I get is around this term legality. Is it legal, right? And it's really not. That's not the right term to ask. Really, the question is, what are the pathways that allow it for it to be utilized? And there are pathways for utilization of stem cells here in the United States, absolutely.
Well, there's people that confuse stem cells with thinking that you're harvesting babies and
Correct.
stuff.
Well, that's
right?
another
That's a big one.
Yeah, that's exactly right. And that's probably something that we should address, which is, what is the definition of stem cell and
where does it come from?
Where does it come from?
Right.
Exactly. So I'll start with that. The definition of stem cell, and this is why it's challenging because the definition is very broad. So in order to be classified as a cell has to be able to replicate itself. So it's going to divide and make two, think of a twin. It's going to be the same cell. And it also has to have the capacity to be a different type of tissue. So it's got to have a capacity to what we call differentiate. So a lot of different cells will fit under that classification, right? Because if it meets those two criteria, then it's a stem cell. So, but when we think about development and when stem cells were first being investigated, people were utilizing what's called embryonic stem cells. And that is in fact a cell type that will become a human being. It's going to be an embryo. It's going to, when a sperm and an egg meet, that's an embryonic stem cell, and it continues to divide. And those were utilized early on and had lots of complications for starters. That's where you had a lot of cancerous material that were being developed. And because, again, these are wanting to be a human organism. It's trying to be a human. And then
that sounds crazy.
Yeah. And then there's the whole ethical side of that when you're utilizing embryonic stem cells. Like when is this an organism that's living and breathing? And that's a whole nother conversation.
Right.
So, but when the cell starts to differentiate and basically mature, I kind of equate it to when you see, oftentimes you might see in somebody's house, like their kids as they're in like the first day of kindergarten and the first day of first grade and then the first day of second grade. And so you see this maturation process, right?
Right.
So it's the same thing with stem cells. They mature and they differentiate. And what that means is the broadness with cell types that they can become or with tissue types that they can become narrows, but they're still a stem cell. So what I mean by that is if you look at your liver, for example, the liver is riddled with lots of different stem cells, but the stem cells are intended to become a liver. You're not going to take a stem cell out of a liver and put it in muscle and think it's going to become a muscle. So it still has the definitions, right? It maintains its definition that it can self-replicate and it can become different types of tissue, but it's not as broad as it was early on in that maturation process. So you just get this narrowing of different tissue types that it can become, and we remove the ethical component because it's not going to become an organism. It's going to become a specific organ, and you don't have the complications that you have with embryonic stem cells. And so this is where we got into the space. So the most common cell type that we're looking at right now is called a mesenchymal stem cell. And that's a specific type of stem cell that can become bone, it can become cartilage, and it can become ligaments. And so that's an important type of stem cell in the space of orthopedics, because that's basically what we're trying to regenerate.
See, that blows my mind when you say that, because I'm like, how do you find those cells?
Yeah.
Like, how do you pull those out of everything else?
Yeah, so that's a great question. So there's basically two main sources for mesenchymal stem cells, and that is the umbilical cord. And so this is another way where things kind of get confusing, because we're talking about babies and we're talking about embryonic stem cells, but now I'm talking about a specific type of stem cell that comes from a specific region, right? So we're talking about the umbilical cord. So
it is no longer attached to a baby.
You got it. Okay. You got it.
And
you
gets
got it.
thrown out.
Exactly.
Right.
Exactly.
Okay.
So yes, following a full-term healthy pregnancy, a normal delivery, usually a C-section, almost exclusively C-section, baby's delivered, umbilical cord is cut, dad cuts umbilical cord, everything looks well, baby goes to mom, dad, baby are all happy. Usually you'd even turn your eye to the umbilical cord and the placenta that comes out after, which oftentimes the medical team is looking at to make sure there's no complications, making sure it's normal, and then yes, exactly right. Once everything looks normal from that, it's discarded and usually thrown into the biohazard waste. But it's been found that it actually is a great source of a specific type of stem cell. Again, the mesenchymal stem cell. It's a great source of those specific types of stem cells that can be harvested and utilized for regenerative capacity.
Now, do parents have to give consent for that to be used?
Yes, they do. Yep. And there's specific qualifications that the parent has to go through in order to be a donor in that sense.
Oh, wow. Okay.
So it doesn't matter. I mean, you can take a stem cell from that and use it in anybody?
You can.
Okay.
You can. And so we call that's what's called allogenic or allogeneic, which means it comes from the same type of organism. It's still human, but it's not yourself.
Does blood type matter or anything like that?
In this sense, it doesn't, because because they're so young, so to speak, they haven't matured to develop these various types of proteins. So we call them immune privileged, meaning they don't tend to elicit an immune response when they're utilized in another individual.
Do you see a world where in the future where babies that are born, they keep some of those cells for that child for the future? I mean, that would be ideal, right?
Well, that's already actually done, where parents can pay to have the umbilical cord and the placenta stored, and they can be utilized to utilize the specific stem cells. Typically, right now, for specific types of pediatric or childhood cancers, usually some sort of leukemia or lymphoma, that they can actually go back, harvest that tissue, and use it for the baby, exclusively for the baby itself.
See, I should have thrown the freezer in the garage.
This shit is wild, dude. Yeah. Like, I know you hate this question, but honestly, it sounds like the movie The Island. I told him this. I'm like, you guys like growing people, like duplicates somewhere else?
Not yet.
It's freaking gnarly.
Well, maybe.
Yeah, I don't know. Maybe somebody's doing that, but not under my watch. I don't know. That's not our space.
I love the fact, too, right? You talk about these ethical issues. I mean, I learned a ton just coming in there. And doing that video with you and just going through, I'm like, man, people have talked to me already about stem cells, and I'm like, I actually learned a bunch of stuff. But the one that I really thought was cool about it is because you deal with all these ethical issues. Oh, is it coming from a baby? Is it whatever else? But then you talk to me about, well, we have the option. We just pull your stem cells.
Correct. Yeah. So we just talked about one specific source of stem cells, which is the umbilical cord. So obviously that doesn't come from you, which is why we call it allogenic. There's another classification of stem cells which comes from yourself. So we call that autologous. So we can harvest it from you and utilize it in yourself. So within your own body, you have a large number of mesenchymal stem cells. And the two areas that they can be harvested from with relative ease is bone marrow or your adipose tissue. So those are the
I'm out on bone marrow.
Yeah, the bone marrow is a little bit of a tricky one. So yeah, you usually go right into, you're usually lying on your belly. You can go with a little trochanter. You drive it into the pelvic
Is trochanter a nice word for drill?
It's non-electrical,
Yes.
you know, so you're just kind of driving a little rod with your hand.
Bro,
you're not actually pulling a trigger on anything and spinning it. You're just driving it down.
I was a medic, and we had those before we got to power tools.
I know if you're talking about like intraosseous.
Yes, dude.
Yeah, that's a drill.
And then you'd have to do that. Yeah, you'd have to pop it into like their femur. And then we got the drills, and it was just like,
Yep.
I
Super
imagine
easy. So
in
we're
your
still
practice,
not using the drill.
I imagine in your practice, it's not very painful. I'd guess, right? I mean,
Yeah, so we tend to lean towards the other source, which is adipose. So we do mini liposuctions, and that's a great source of mesenchymal stem cells as well. So we've gone away from the bone marrow.
Adipose, is that like, that's not belly fat?
That's
Is that
belly
like
fat.
Organ
Belly
fat?
fat.
Belly fat, okay.
No, belly fat, not organ
I don't
fat.
have any, so.
he already told me, he goes, it's not cosmetic, dude. It's not going to change anything.
When I go do this, I'm going to have them use your adipose tissue.
You should
don't
put my
have
fat
it.
inside of you, for sure.
Yeah, well,
Sounded
then you
gross.
can have rejection, so you can't use that.
Okay.
You can't,
Can't use
this is the one space that you can't actually use
I
it for.
reject him in many ways, so my body would
I know
definitely
you
reject
do.
him.
Yeah. But yeah, so it's a small sample. You're awake during the procedure, a little bit of soreness after, a little bit of bruising, but generally tolerated really well. Generally not enough to create any significant cosmetic changes. That's usually the question I get is actually, are you going to help me out here with my belly fat? But it's not a huge amount. And then, so we can do a mini liposuction. We take that, we throw it in the centrifuge, we can filter it to narrow it down to an isolated sample of the MSCs. And then we can use that for orthopedic conditions. Or I think we talked about stem cell banking, which is the other one. Right. So you can actually just like we talked about utilizing the umbilical cord and the placenta for the child, you can actually bank your own stem cells. And so you can have them for a lifetime. And you won't have to repeat the mini liposuction if you needed a future procedure.
Okay. Well, that's kind of cool.
Yeah.
Is one better than the other? Am I wrong? I thought that your body fat stored toxins as well. Does that matter?
That's a good question. Well, what's interesting is that's part of the reason. So does it store toxins? I think maybe is a different question, but we're going to spin it down and we're going to filter it again. So we're isolating the stem cell that we want. And then to your question of which one's better, you're talking about bone marrow versus adipose. Yeah. So that's an interesting question. And if I start from clinical trials and look at, what the outcomes show, based off bone marrow versus adipose, and even the umbilical cord, none of them really show that one is like excelling past any of the other ones.
Okay.
They're all relatively in line. Now, some things that we do need to think about is what's the baseline health of the patient, if they're relatively healthy at baseline, thinking about, what's the efficacy of their own stem cells. Are they older? Are they obese? Do they have underlying medical conditions? That might dissuade you from wanting to use your own. But otherwise, there's not a significant, huge discrepancy with any of them. So it kind of comes down to personal preference and tolerance and comfort level of the procedure.
Okay.
Yeah.
So going back to when we talked about it, you said before we do that, we have to basically create an environment that's conducive to growth, right?
Yeah.
So it's not like you can just inject stem cells and go with it. Because we talked about the recovery process when you have an injury, that your body sends certain platelets and all sorts of stuff to that area, right? So what?
Yeah. So what we talked about is the wound healing cascade and how that process works, and so that's where we had a good conversation around platelets, because platelet-rich plasma is one of the, we talked heavily about stem cells, but there are other regenerative materials out there, and platelet-rich plasma is another one that offers great support. Why is that? Platelets are a normal cellular property that is running through the bloodstream. So you all have platelets in it. You got your blood check, you get a CBC, you're going to get a platelet count. And platelets are part of the first cellular component that arrives at a site of injury. So if you have an injury, platelets are going to come in and they're going to start that wound healing cascade. So why do they do that? Because within platelets, they have all of these signaling molecules that help the immune system kind of get activated. It helps to recruit white blood cells and your internal stem cells. So it's recruiting all of these materials, all these other cells to say, hey, there's an injury here, we need to recover, and it goes through the other phases of wound healing. So platelet-rich plasma has been around for a long time because of that initiation of the healing cascade. So let's say, for example, you have an injury. I injured my shoulder 10 years ago, and it just kind of is lingering and is continuing to bother me, and it hasn't gotten better. Usually that's because that injury has gotten stuck somewhere within that wound healing cascade, and we haven't been able to progress through the remodeling phase to allow for full tissue redevelopment. So the thought behind that is, well, let's throw some platelets in there again. We can concentrate platelets. We take some blood out, we concentrate it, we get those platelets, we put it back in there, which reinitiates that healing cascade, taking it back to phase one of healing, wound healing, with the hope that it can progress throughout those. Now, to get back to what you were talking about earlier, which is how I utilize PRP or platelet-rich fibrin, which is a subtle difference, and we can talk about that. But the idea for that many people have is we can just throw stem cells anywhere and they're going to regenerate tissue. And it's not necessarily that easy. Stem cells are actually very, very tenuous. They need to be supported, or else a good portion of them are actually going to die within the first 48 hours that you inject them. Your body's going to clean them up. They're going to degranulate. They're just going to degrade. But what we want them to do is embed into the tissue. And like I said, for mesenchymal stem cells, if we have a tendon injury, then I want it to become tendon. I want it to heal, right? I want it to fix the defect that we have. And in order to do that, we need to create the environment that's going to allow the stem cell to be most successful, right? So how do you do that? Well, for starters, just injecting stem cells into an area that is osteoarthritic or has some pathology with which we know these injuries are going to have an environment where the pH is altered. It's going to have matrix metalloproteinases that are going to degrade cells. It's going to be not a favorable environment to just inject stem cells into, because the majority of them will die. But this is where my approach is different, where I prep the area, oftentimes with platelet-rich plasma, because they can alter that pH. They can start to bring in some of the immune system and create a more favorable environment that allows the stem cells to come in, remain in the area for longer periods of time, and ultimately embed into that tissue to become new tissue and allow for regeneration. So this is where I struggle with, there's a lot of people that say, well, I had a stem cell injection, it didn't work, or I had this treatment and it wasn't effective. And you start to get into the nitty gritty and you're kind of like, well, I didn't really agree with the placement, or I didn't agree with the cell type that was used. But ultimately people think that we could just throw stem cells as a one and done and it's going to be, fix all your problems.
Right.
When you go back and you think about it and you say, well, we didn't actually prime that area and give it the most, give it the greatest opportunity for success, because we just spattered stem cells in there. And yeah, they were probably all gone within the week that you got that procedure. So it's just less effective.
Now, I know we talked mostly about, musculoskeletal and stuff like that. But you also talked about, and this was brought up the other day. I have a friend that has MS. Okay. And she's going through, a ton of stuff. Obviously it's a very slow degenerative disease. Right. And she's going through a lot of that stuff right now, just little struggles. And she's trying out a bunch of different, a bunch of different treatments and everything like that. And, you talked about some systemic stem cells.
Yep.
Talked about my previous Guillain-Barré, that might work. How is that stuff in modern medicine? How is the effect of that stuff having on things like MS or other systemic diseases that are progressive like that?
Yeah. And so MS is an autoimmune disease where your own body is attacking the nervous system, usually the brain and spinal cord. So it's very unfortunate disease, and the whole world of autoimmune diseases are particularly challenging because you're just in this space where my own body is doing this to me. It's like, why is my body attacking itself? But this is actually in the space of regenerative medicine. If we take a step back, regenerative medicine has taken kind of hold within the cosmetic space initially, because a lot of the knowledge around stem cells and healing started with our understanding of skin. The skin just has a great capacity to heal itself, right? So what are the properties of skin that allow us to learn from that and transmit that to other areas? And then orthopedics kind of got into that as well. And now we're just seeing this explosion in cardiac regeneration, pulmonary regeneration, neuroregeneration. And so those areas are relatively early in their understanding and their application, but where I really see a lot of potential opportunity and what I anticipate being the next space where it's going to start to really have great impact on patients is in the autoimmune space. Because when we think about, or when we see the aspects of regeneration that systemic stem cells are doing, and so maybe we should take a step back. Systemic stem cells is when you are giving stem cells through an IV. So it's going throughout the body. So we call that systemic, as opposed to what I was talking about earlier, which a lot of what I do from an orthopedic standpoint is a direct local injection, right? I have a tendon injury on my shoulder. I want to deliver stem cells directly to that area. We're going to do an injection. So we call that local, versus systemic is I want to deliver these throughout the entire body. And why I think that's going to be so impactful for autoimmune diseases is because of its ability to what we call immune modulate. It has a great capacity to support the immune system, and it can actually alter the course of these autoimmune diseases by suppressing its abnormal activity, reducing its abnormal function to prevent your body from basically rejecting itself. Right now, your alternative is immune suppression, which comes with its other complications. But I do see that the world of autoimmune rheumatologic conditions is likely, in my opinion, going to be the next area where we see a lot of growth and a lot of benefit for patients.
That's cool.
Yeah.
Do you see, we got to get Seth in there. I need this guy to get fixed. Do you see a lot of, so you get a lot of people that are coming in, sounds like mostly musculoskeletal, right? How, and this seems like more of, I don't want to use the word cure. It's not a cure, right? But we're trending in the direction of fixing the issue as opposed to masking it,
right,
which is 90% of medicine. I hate to say it. When I was a paramedic, I went through medic school and everything else. And when I look back at a lot of it, it was frustrating me to look at the fact that I was treating symptoms and not the underlying problem, right? And I think that a lot of doctors, people get frustrated with doctors. I've been to this guy forever and I'm just on these meds. And a lot of times they're treating the underlying the symptoms and not the underlying disease.
Yeah.
This right now is not an insurance thing, right? You pretty much have to pay for it.
Correct. So there's no role for insurance right now in the world of stem cell treatments.
Is that mostly, and maybe you don't know this, but I mean, it seems like, the pharmaceuticals and everything else is a multi-trillion-dollar industry, right? I mean, you're talking, they run just about everything.
Yep.
The opportunities to actually fix issues and put people at bay, put people at rest, and not come back to the medical field, right? To get more treatment down the road. That's a little bit. Is there a pushback from the pharmaceutical industry and other things against stem cells? Because I know that getting approvals and
at least until they figure out how to patent it and make money.
Right. I'm sure it comes down to money for sure.
Yeah. I mean, there's a whole. We could have this conversation on another podcast about the failures of the healthcare system. And I think it goes beyond the pharmaceuticals, right? This goes into conversations around insurances. They basically operate as a business. Even hospitals, they're business. Everybody's got to make money in this space. But, to your question, I try to stay away from, who the worst players are and the conspiracy theories around trying to keep people sick. I try to stay away from that.
If you get into that, we're drinking whiskey. So.
Yeah, we'll have to break that open
crazy.
for sure.
It's within arm's reach. I'm just saying.
Until then, I'll stay away from that conversation. But I think that a number of things, this regenerative medicine is disrupting healthcare. There's no doubt about that. And how it's going to be accepted within insurance or hospital systems is kind of to be determined. I mean, I think that it's going to find its way out there. The biggest hurdle right now that it's going to have to overcome, right, is the FDA, right? So the FDA is the one that is, and again, I don't want to try to have any bad image towards anybody, but the FDA is intended to ensure that the food and drug that we're ingesting is safe. And believe it or not, platelet-rich plasma has been around for 20 years, is proven to be safe, and is still not FDA approved in many instances.
We're pretty much against any three-letter government organization. So,
you're not going to hurt your feelings here.
It's all good, and not, I understand that entirely. I think I want to give credit where credit is due and kind of remind ourselves of what the intention of some of these organizations are supposed to be, and whether or not they're, manipulated or whether or not they're persuaded by things, that's always potential. But its intention is to ensure safety. And one of the challenges across these boards is that it's not uniform. And what I mean by that is if we think about Tylenol, for example, Tylenol is Tylenol, whether you buy it from Safeway, CVS, wherever you go to buy Tylenol, it's Tylenol.
Regardless of the name.
Doesn't matter.
Yeah.
But when I take your platelets out and I take your platelets out, those will never be uniform. Your platelets are your platelets. And so it's hard for me, or for the FDA to say, yeah, platelet-rich plasma is safe when it's non-uniform. The concentration is different. The efficacy is different. So you're not dealing with something that's homogeneous across the space. And platelet-rich plasma is a microcosm of the complexity of stem cells. So when we think about what is the pathway for FDA approval, I'm not sure that there's ever really going to be a pathway for FDA approval. It's going to be a pathway to say, we think it's reasonable to take this approach. And that's effectively where we're at right now. So when we go back to the very beginning, we talked about legality. It's not necessarily whether it's legal or not. It's, are we reasonably treating something that can show a response to stem cells? And are we getting the stem cells from a lab that is FDA approved, that they're doing safety testing, that they're making sure there's no infectious diseases? And ultimately, is the treatment that we're utilizing it for reasonable for that sort of condition? So that's the space. And so I start there because when we think about that effectively being transitioned to insurance authorization, that's the first hurdle that we would have to overcome.
Got it.
And then we're not even there yet with platelet-rich plasma, which has been around for longer than stem cells. So I'm not certain what that timeline would look like.
Right.
And so again, I think that it's not going to be necessarily an FDA approval. It's just going to be pathways that are more spelled out to say, yes, this patient is a good candidate and it is reasonable and medically appropriate to utilize this as a treatment.
It's tough because I think, you think of people that have issues that could be solved with stem cells, 1, 2, 3 injections over time and stuff like that. And the amount of money that you spend in dealing with that chronic disease, whether it be medications or continued treatment somewhere else or whatever. It's nice to know that there's at least an option that potentially I think it's scary for a lot of people because up front they're like, man, if this is something I have to pay for,
Yeah.
That's tough.
Yeah. And it's not cheap either.
Yeah.
But again, it's an investment into your health. It's an
Right.
investment into your health.
Can we talk about peptides? Are you in
Sure.
that space as well?
Yep.
Okay.
Yep.
Because that's getting huge right now. I think
It is.
just about every guy I know takes peptides and testosterone.
I
so-
stopped taking them because they're a pain in the ass, dude. I've talked about this.
What about?
There is a fatigue that you get from self-treatment. There is.
Oh, when you're sticking yourself in the needle 3 times a day?
I
Yeah.
started the BP
Yeah.
157 and all this other stuff. I'm like, these are
Yeah.
great. I'm going to do these. And then after about 2 months, I'm like, this is bullshit, man. I got to go and stick a needle in my stomach every day.
Hey, heroin users do it like 10 times a day, bro. Okay. Are you even trying?
And they're just fine.
Are you even trying?
Yeah, but that is one of those things where there's a convenience factor for anything. I mean, we're both on testosterone.
Yep.
When I started doing it, I'm like, I'm going to be the guy that's super level. I'm going to do it every other day.
Mm-hmm.
Well, quickly, I'm like, all right, well, this is getting a little monotonous, right? Next thing you know, now I take my testosterone twice a week.
Yeah.
And even that, I'm kind of like, ugh.
Yeah, the day comes around, you're like, this is annoying, but yeah, it only takes me a minute to do it, but yes.
That's my only
I do it
gripe
3 times
about
a week.
peptides, but I'd love to hear your take on them.
Yeah.
Yeah, so I kind of hesitated just because we don't sell or distribute or even recommend peptides,
Okay.
but they do oftentimes come up in consultation. They're so popular and everybody's interested in what their potential is. And so I do give guidance on peptides and peptide therapy. We're, again, going into this whole space of none of these are FDA approved. The literature around it is somewhat limited. But this is actually a space that I really enjoy, both the stem cells and peptides, because we're at the forefront of medicine. So
Yeah.
the opportunity or the potential opportunity is there, but there's still some acknowledgement that several of these are very novel in both their efficacy, but also in their side effect profile. So those are the conversations that I have with patients, but I don't necessarily recommend them to anywhere. I don't have a source that I would recommend patients to go to. And like I said, our clinic doesn't sell or prescribe or, distribute any peptides in any manner.
There are a few places in town. I get mine online, which is always a risk, right?
Yep.
It literally says not for human consumption on it. But there are a couple places in town that do. And I believe, I'm 99% sure on this, that Idaho pharmacists can prescribe it. And there are pharmacies that will be carrying them or are carrying them.
So this this is regulated by the FDA, of course. So the FDA not only oversees laboratories with which you acquire stem cells, but also oversees pharmacies with which you would get pharmaceuticals. And there are different classifications of pharmacies. Your traditional CVS pharmacy or Walgreens pharmacy is your classic pharmacy that will have all FDA approved medications. Then you have a whole space of compounding pharmacies. And it's the compounding pharmacies that have slightly different regulations from the FDA and are allowed to compound, medications, usually that are, say, for example, there's a medication that you want to prescribe for a patient, but the patient doesn't tolerate that specific type of, delivery, i.e. they don't want to do an injection.
Right.
But the only FDA approved delivery method is injection. And so you could say, well, I want a compounding pharmacy to develop an oral compound for that. And that's not an FDA approved, but that pharmacy under their FDA classification can in fact make that. So that's kind of a general example. The other one is, which one we just kind of ran into recently, which is for the GLP-1s, that some medications may be, they're just limited in availability, right? There's a national shortage of a specific medication. And under certain criteria, then
because of the Kardashians,
yeah, exactly,
using all that shit up.
They need it.
Yeah. So they're just so popular. They're being prescribed so frequently that there's national shortages. And in those instances, compounding pharmacies can step up and they can produce them, again, under a limited time, under the FDA's approval, and then that can go back. And that's what we just ran into with the GLP-1s, in which they were available from compounding pharmacies. But then the FDA said, we're no longer under a shortage, so now they're no longer available. And I qualify all of that information because the assumption is that if a compounding pharmacy is making a molecule, that it must be FDA approved or authorized, but that's not always the case. So compounding pharmacies can certainly be producing medications that are restricted by the FDA. And so that would not necessarily be legal under their authority.
What's the GLP-1?
That's the weight loss ones.
Things like Wegovy, Semaglutide.
I thought there was an Ozempic was what I was thinking of.
That's the GLP-1, right?
That's the brand name.
Oh, Ozempic is GLP-1?
Ozempic or Wegovy.
Yeah, I didn't think it's a peptide, right?
Well, yeah, okay, yeah.
Kind
so
of.
we can talk about...
Because I've heard tons of controversy over Ozempic.
Yeah, that was the classic. That's the Semaglutide. Yep, Ozempic is a weight loss medication, GLP-1. And I assume the controversy you're referring to is some of the side effect profiles.
Yeah.
Yeah.
Because I didn't know that was a peptide, because all I've heard about peptides is that they're natural,
and that's
body
why
produces them, whatever
and
else.
again, very similar to like stem cell definition, peptide definition is just poorly understood, because if you look at peptide, all it means is a short chain of amino acids. So it's just a protein. And so the number of proteins that fit under that definition and that classification is endless, right? I mean, so there's so many. But the idea is that it's a naturally occurring molecule within your body that we can, create in a lab. You just mimic it, and we call it a peptide. But that spans all kinds of different biochemical processes. So right now we're talking about weight loss, but you talked about BPC-157, so that's a VEGF analog, and we could talk about that later. Or growth hormone analogs, or growth hormone releasing peptide analogs, or naturally occurring peptides for increasing testosterone, right? So your testosterone releasing hormone type of peptide. So there's a whole classification. So peptides is, again, just kind of a poorly defined term. So sometimes it's difficult to talk about. But yes, generally speaking, we would refer to semaglutide or the GLP-1s as a peptide because it's naturally occurring.
Here's how I know peptides work. Well, I've taken BPC-157, TB500. My wife's used C-Link and C-Max. Those are newer ones for brain stuff. Yep. I had a buddy, this was years ago. I cannot remember the name of it, but it was a peptide to darken your skin because he was going to...
Melanotan.
Yes, he was going on vacation, and he wanted to get a tan before he went. So he took this, and he's a white dude, it turned him damn near black. And it was hilarious. And, being a guy,
awesome.
I'm like, Like, are you black everywhere? And he's like, yeah, bro, everywhere. I was like, that is wild. So yeah, it works.
Yeah.
Disproportionate.
That was a perfect example for me. No, not proportionally, just color. Yeah.
Yep. And again, this is, I don't want to conflate FDA approval with efficacy. We don't want to, those two are not necessarily analogous. I think there are some things that are very effective that are not FDA approved. And on the flip side, some things that are FDA approved that are ineffective or have a side effect profile that's very limited. So we have to be careful with not conflating those two. But there's still a fair amount of research that's needed that will help to move the availability of peptides more widespread.
Cool. Yeah. I mean, it's like the ATF. Like, they ban all the cool stuff. So
well, it's crazy because we're so separated from the actual like base level knowledge nowadays and everything. I mean, everything's so complicated.
It's hard to get information on these things.
I mean, you can send me peptides and tell me what's in there, and it could be gelatin.
Yeah, who knows?
I have
Correct.
no idea.
Correct.
Right.
You could be sending me the vaccine. You could be sending me all sorts of stuff. I have no idea what's in it.
Yeah. Usually you look for something that's third party tested and you try to get something validated. And that's where you feel relatively safe from a compounding pharmacy because again, they have to show or present some degree of purity. But yes, there's still a lot of uncertainty when you're purchasing things that are direct to consumer. And so you have to be careful.
Right. And it always seems like when somebody's proven that, oh, you guys screwed up, you didn't do it right, is after the fact that a million things have been shipped and you know what I mean?
You got it.
It's crazy.
You got it. It does take time, yeah.
I have an admission to make. I took a GLP-1 for about 2 weeks because...
Did you?
Well, I wasn't using it for fat loss. I was using it because there was talk of it healing the stomach.
Mm-hmm.
Like getting rid of the fat?
No, like the internal stomach, and then balancing blood sugars. So I my entire life I've been not like pre-diabetic, very close. All my blood work always comes back.
Mm-hmm.
I can't remember.
Hemoglobin A1C.
Yeah. Which frustrates the hell out of me. I live pretty clean. I eat clean. It's like annoying.
Mm-hmm.
Maybe it's hereditary. I don't know. So I was trying to manipulate that. But about a week into it, I felt full all the time. I would eat like this much food, and I'm like, I'm full, and it like felt gross, like I was in my throat, and I was like, this is stupid. I couldn't handle. I'm a fat kid inside, and I'm like, I need to eat.
Really?
So not being able to eat was very frustrating to me.
Mostly like an appetite suppressant?
Yeah, well, so there's a couple different mechanisms. Yes, there's a lot of centrally acting mechanisms where it does reduce your desires of hunger. So it's reducing hunger and ultimately reducing caloric intake. There's also a mechanism of delayed gastric emptying. So the stomach will
That's probably what I was feeling.
Right, exactly. So the stomach will remain fuller for longer periods of time despite eating smaller amounts because it just doesn't move things along forward. So that's probably the side effect.
Activating all those coloreceptors in the stomach and everything else tell you that you're full.
Yeah, it's telling you your brain's full, and then it's also slowing down that GI system, so less absorption. Ultimately, with the reduction in caloric intake, which is what's leading to the weight loss.
I have mixed feelings on it. I mean, I feel like if someone's extremely obese, that's a great pathway to lose weight. I mean, because sometimes that first step of getting, if you're 500 pounds, it's hard.
Yeah.
You're fighting a hard battle. It's hard for guys that are somewhat fit to lose any weight. So I get it. And I mean, if that's the jump start you need, I'm all for that.
Well, when you look at people, some people will take it. I mean, you really got to ask, does somebody, somebody that's mildly overweight or, they're still extremely active, is it necessarily going to lead to a healthier lifestyle for them to lose some fat? But there's some people that, if it's going to help you lead a healthier life down the road, right? Then what's the difference between that and then going in and doing a liposuction? Like that's traumatic to the body as it is, right? And honestly, it doesn't teach you any habits or anything else. It just cleans things up. You go right back to where you were. So, if it's leading people towards a healthier life,
it's better than eating yourself to death.
100%.
The truth of it.
And that's the conversation that I have with patients with regard to the GLP-1s is we need some sort of off-ramp, right? I mean, if your expectation is to just take it for a lifetime, that's a consideration. But ultimately, as I mentioned before, the efficacy of this is around its caloric reduction. So it's a reduction in oral intake. So at the end of the day, if you were to control your oral intake, then it's the same thing, so it is manageable from a lifestyle standpoint, but easier said than done, right? Dieting itself is really difficult. But, and then to refer back to what you had said earlier is around the controversy, which is, well, what's the impact it's having on brain, right? Because it's centrally acting. And there was initially reports of maybe it's increasing depression or suicidal ideations. That seemed to not be the case. More research has come out that has not really supported that. But the big one being, the loss of muscle mass. And so when you lose weight, you're going to lose not only fat, but you're going to lose muscle. It's just hard to lose isolated macronutrient, it's hard to lose fat by itself.
Right.
You're going to lose muscle mass along with that. But if you're strength training on top of that, you can reduce some of that loss of muscle mass and maintain some good body composition. But again, at some point, I think there's, this is a conversation that I have with patients, you have to think about what that transition looks like to ultimately come off of it, to allow you to reach your steady state end goal weight or body composition, whatever it is the end goal is, and then ultimately come out of that and maintain that lifestyle over time, which is a big challenge. So oftentimes people do regain the weight after because they've not been able to deal with the management of the lifestyle factors to really control the caloric intake.
My new personal routine, I've been doing this about 2 weeks, and I'm no stranger to fasting. You probably have a lot of knowledge on fasting, I'm guessing, so that's why I'm bringing this up. So I've been skipping breakfast. So I'm eating dinner. I don't snack after dinner. Nice. And then I'm fasting until 11 or 12 the next day, just eating lunch and dinner. And I find, my goal with this is to manage that pre-diabetes that I talked about because it frustrates the hell out of me. And so I'll get my blood work. I'll try to maintain this for the next 6 months and get my blood work done and see what the difference is. But, what are your thoughts on fasting? Do you have a protocol for that you use or recommend?
So I have a little bit of nuance here in that I refer to fasting as anything that's 24 hours or longer.
Okay.
So anything below that I would refer to as time-restricted feeding.
Sure.
And time-restricted feeding I think is a great way to control caloric intake. So if I'm trying to reduce caloric intake or, manage what I'm eating throughout the day, reduce snacking, it's a means to control what you're putting into your body, and reducing the number of hours with which you allow yourself to eat is a great tool to do that. So I'm a big fan of time restricted feeding, but I do see that as solely a way to control calories. As opposed to like a true fast, which is 24 hours or longer, which has different biological, cascades, which really support regeneration. So this goes back actually into stem cell conversation, because when we fast beyond 24 hours, we're actually starting to mobilize stem cells into the body, which can really impact regeneration and healing and support the immune system. So that has a different impact when we take that fast to 24 hours. Usually, so my protocol actually is usually doing a 24-hour fast once a week. I usually don't eat from Friday night until Saturday night, and so 24-hour window there.
Oh,
and I do that
like 2 nights I want to eat.
I know. Well,
that's a rough one.
It is a tough one, and if you wanted to change that to a work day, you could play with it however you wanted to, because usually being at work is a little bit easier. Your mind is occupied. You're not at home where the pantry's just staring at you, or fixing up dinner for your kids, that sort of deal. So, anyways, once a week, doesn't matter which day you do it, and then quarterly, over the course of the year, I'll do a 72-hour fast. So I'll take it a little bit longer.
I've done one of those. Yeah, it was 3 or 4 years ago now, and I was like, it was gnarly because I do a lot of the cooking. Yeah, I literally cooked bacon in the middle of a 72-hour fast. I'm like, that takes fortitude.
Well, there's that the big 86-hour fast that's out there right now. Yeah. So I did that one. Yep. And all the talk was about the cellular level, the regeneration, and all that stuff. So I'm guessing it falls in line with that too.
Yeah, because you're really shifting. So I'll just give you an example. Typically, when I'm doing a 24-hour fast, the idea is that you're shifting your biochemical processes, right? So a little bit of science here. You're generally utilizing fat and sugar as your fuel source, but a majority of that is coming from fat at rest, and then you can increase your glucose. But generally, there's enough sugar in the blood that you're not necessarily transitioning into creating ketones, right? So this is where people do a nutritional ketogenic diet or nutritional ketosis. And I tend to not get into ketosis until I reach that 24, sometimes 36-hour window of fasting. And I have a ketone monitor at home, so I'm checking my ketones, and there's a threshold with which you're officially in ketosis when it goes above 0.5. So I reached that threshold between 24 and 36 hours. And so that indicates that my body is utilizing fat as a greater fuel source and mobilizing ketones into my body, which is a great fuel for the brain, in fact. And so people tend to feel more cognitively enhanced, their energy changes a little bit. And so that's kind of what I'm talking about, where you get that that change in biochemical processes beyond the 24 hours that you don't necessarily see in shorter, fast or time restricted.
So I may not be getting that, but I wouldn't know unless I tested my blood.
Yeah, I think it's highly unlikely. The more you fast, if you are doing it with relative frequency, if you're doing 24 to 72 hour fast in a regular frequency, you're probably going to get into it faster. So again, and that's why people tend to not feel well within that 24 to 48 hour window. You have headache, you feel fatigued.
Yep.
That's because your blood glucose has dropped, but your body hasn't mobilized ketones to get that energy level up. So it's a tough window to do when you're doing water only fast, because you got to get over the hump until you start to get those ketone levels up. So, but the more you do it, the faster you'll get into that ketosis.
Okay. Do you think with time restricted feeding, are you getting any benefits of autophagy? Is it even happening?
Yeah. So autophagy is such a great term, and mitophagy.
I just wanted to say it first.
Yeah.
That's why I brought it up. Yeah.
You did.
I'm pretty much a doctor, bro. Yeah.
Exactly. No, it's great. I'm glad you brought that up, because autophagy is this like recycling of cells, right? It's the body's ability to basically take proteins that are misfolded and cells that are not as functional and say, you know what, let's take that, recycle it, and make a new one. And so autophagy is when you do that at the cellular level. Mitophagy is when you do that with mitochondria. And mitochondria is an important organelle. It's one of those, one of the structures within a cell that's important for ATP production, right? We typically call it the powerhouse of the cell because it's generating ATP. And mitochondria are just so important when you think about the cellular changes of aging that's associated with aging, and mitochondrial dysfunction is at the top of that list, as that results in cellular aging. So we really want to pay attention to mitochondrial function and keep them as healthy as possible, which is why exercise is so important, cardiovascular health is so important, hyperbaric oxygen therapy, that type of thing is so important. And getting into autophagy and or mitophagy is one of those cascades that really occurs beyond the 24-hour mark, usually even beyond the 48-hour mark. So if you're trying to get that, time-restricted feeding is certainly not getting into that phase. You'd probably want to get it into 48 to 72 hours to maximize that process.
So I'm really probably just getting calorie reduction.
Correct. Yeah, you're managing calories, which is good. And going back to what you said earlier, which is one of your primary goals is blood sugar management.
Yep.
And so that's certainly, yes, you're managing your blood sugars in between those feeding windows, because you're not snacking, you're not, whatever your window is, everything outside of that, your blood sugar would be hopefully relatively normal. This is where CGMs could be very helpful, continuous glucose monitor, where you can throw that on and you can actually see what your blood glucose is doing.
Those are becoming pretty popular. Those are on a lot of people now.
Yeah, they're really popular because, again, it gives you some insight as to what your blood sugar is doing on a minute-by-minute basis. And you can, usually you can wear them for about 2 weeks consecutively, and you can see what your blood sugar is doing throughout the course of the day. And then, for my patients, I'm kind of giving them metrics with which I want them to stay under what I want. I don't want your blood glucose to spike above a certain number, and I want in between, while you're in between meals, that it should be coming down to a certain level and maintaining below certain levels. So there's metrics that you would want to measure to kind of help monitor, particularly your blood sugar values.
It's probably helping because I feel less of those hunger like spikes. My biggest challenge is getting. I haven't tracked it, but I'm probably not getting enough protein because it's hard to eat that much.
That's such a good point. And yeah, I mean, we can get into that as well. But somebody of your, because how much do you weigh?
215.
215. So got good muscle mass, a good portion. So getting 1 gram, which is generally the recommendation, 1 gram per pound of body weight. You're talking about 215 grams of proteins over the course of the day. And now we have to do that within 6 hours or whatever your window is. And that's a big challenge. And beyond that, there were a lot of, a handful of years ago, there was a lot of conversation around, well, how much protein can you actually absorb in one setting, right? So if you're only eating, let's say, 2 meals a day, and you need to get 200 grams of protein. You're talking about 100 grams of protein in each setting. And so that can be a challenge, and not everybody can absorb that or tolerate that from a GI standpoint. But fortunately, there is some data to show that you can actually absorb larger amounts. It used to be thought that 30 or 40 would be the tops, and generally I would say that that's the minimum requirement that you would want per meal. And this goes into conversations around activating mTOR and maximizing, muscle protein synthesis, which is really how that protein metric is assessed. It's like how much are we able to maintain the muscle mass and activate mTOR, again, the major marker of protein synthesis. And so the minimum is probably around 30 or 40 grams of protein. It gets a little bit into the weeds where we talk about specific amino acids that will stimulate those, those enzymes. But there's now more data coming out that threshold, particularly for people that exercise regularly, that train regularly, and eat on a semi-regular kind of regimen, that they can actually absorb higher amounts and maybe not have any high or upper ceiling to protein intake at any one setting. But you're exactly right that as you increase, or I should say, as you narrow the window, if you're doing a time-restricted feeding, meeting those protein goals becomes harder and harder.
Yeah. What kind of supplements do you, so personally, what kind of supplements do you take? What's your morning routine? What's that look like for you? I'm curious.
So those kind of go hand in hand. My morning routine is I work out first thing in the morning. So I'm up before my kids are up, before my wife's awake, because that's the only time I can do that.
It's the only time you can control. I get it.
Yeah. Once my kids are awake, leaving the house to go work out is just a sacrifice, and feel like I'm leaving too much on the plate at home. So I get up in the morning. I do that first thing in the morning. And then come home, start to do the morning routine with the kids, have breakfast, and that's usually where I take my supplements in the morning, which is I do a magnesium supplement, I do a vitamin C, I do an omega-3, and I do a joint supplement. It's it comes from this company called Salt Wrap. I have no affiliation with them, but I like it. And it just has a number of naturally occurring molecules in there that are designed to support joint health. And then usually I put a couple scoops of collagen protein in my morning coffee. And then throughout the day, I have my creatine.
Cool. What do you, do you eat breakfast, or what is your breakfast?
I do. My breakfast is my biggest meal of the day. So actually I come home, and because I just worked out in the morning, I'm really kind of slamming a big breakfast. It's not uncommon for me to miss lunch because work if work ties me up. So that's where I really kind of make sure I get a good solid breakfast in, because I don't know if I'm going to get lunch or not. Mm-hmm. And then I usually, I'm fortunate, my wife cooks up a good meal usually in the evening times now. So I'll get at least 2 meals a day, oftentimes 3, but the afternoon is kind of hit and miss.
How would you describe your diet? Do you have a name for it, or like?
No,
low carb,
I've done a little bit of it all. I've done actually in medical school. My wife and I took on a vegetarian diet for a couple years. I tried that a little bit. I did do nutritional ketosis for a year or so. This was maybe 5 years ago where I did that. Right now, I kind of just eat with no specific criteria, but try to do all natural foods. I'm big on protein. I do, again, I'm having 30 to 40 grams of protein per meal. I use that as kind of my minimum threshold. But my morning is pretty typically, egg, some sort of breakfast meat, again, some water, coffee. I do that in the morning. Lunchtime, that's where I try. My lunch is usually, that's where I try to get a majority of my fiber. So my fiber is, an important nutrient that we need to get in is fiber, and that's where I get in a lot of that with my lunch, which is usually a salad. So my salad is going to be vegetables, like bell peppers, carrots, cucumbers, a lot of mixed nuts. I'll throw that in there, and usually no salad dressing, just throw some olive oil on top of that. So that's where I try to get some fiber in, try to get 30 to 40 grams of fiber throughout the day. And then again, dinner, usually my wife cooks up some sort of meat and veggie on the side, So there's no real unique aspect to that. I think about the macronutrients. I try to do high protein, low saturated fat, but still high fat. Lots of monounsaturated fats. So that's where the olive oil comes in. That's where I do a lot of mixed nuts. So cashews, macadamia nuts, walnuts, those are huge for me. And then I try to stay relatively low carb. So if I can reduce, I try as much as possible to keep the carbohydrates low. And I use the CGM pretty frequently to watch that.
Can people get CGMs like online, or do you have to get it from a doctor?
Yeah, no, you can buy them. They have direct to consumer. The one that I'm most familiar with is Lingo, and again, I have no affiliation with them, but Lingo is a good one. I think it's $50 to get a month's worth. So again, one CGM will last about 2 weeks, so you get 2 of them, you get 28 days or so.
Oh,
I think
bad.
it's $50, maybe $100, something like that.
Okay.
But I like their app. Their app online is nice, where it trends it nicely in a nice kind of organized,
Easy to read,
easy to digest manner.
They just go on your back of your tricep, or where do you end up putting them?
You can put them anywhere. Most commonly, people will put them on the back of the triceps, but you could put them kind of like lower abdomen or kind of in the flank area. But most people do them in the back of the triceps.
Yeah.
I think I'm gonna do that when we get back. We're going to Australia in 2 days.
Nice.
When we get back.
Awesome.
Well, and send me the data.
You don't want to do it while we're there.
Cool.
Don't do it while we're there.
No, not while you're dead. No, not on vacation. No,
Dude, my glucose out of control.
Well, and I would actually recommend that you wait maybe a week or 2 after you get back, just because your sleep regimen is going to be off. Your circadian rhythm is going to be all messed up. So wait till you get back on a decent sleep regimen, because that's going to throw you out of whack too. Your sleep regimen is going to throw your glucose off. So no, and then also, I don't know, when I'm traveling, I just like to explore, and I kind of give myself a free pass on my diet. Just explore.
I'm not going to worry about it.
Yeah, we're not going to pay
I would
attention
not.
to any of that.
Enjoy your time, eat what you want, work out, obviously, and but then when you come back, after a couple weeks, 2-3 weeks, then we can explore throwing that on. And like I said, I'd be happy to look at the data and help you out.
I would appreciate that. That'd be amazing. This stuff fascinates me. Obviously, I'm just super into it.
So real quick, 'cause we're getting close here. You guys are located currently in Spokane, but you guys are opening up a facility here in Coeur d'Alene.
You got it.
Okay.
We just purchased a building in Coeur d'Alene a handful of months ago. We are in the process of renovating that space, and we're hoping to move in sometime this summer.
What's the name of the practice, and what do you guys encompass in total?
So Clinic 5C, and we're multidisciplinary. We are started by Dr. Cameron Chestnut. He's a world-renowned cosmetic, plastic surgeon, facial reconstructive surgeon. And through that, we had various practices. Regenerative medicine, which is the area that I focus on. I was added about 1.5 years ago, and so I'm focusing on that space. We also have functional medicine, where we do a lot of these conversations about metabolic health, and do a lot of some of the more in-depth blood work, and some of the more detailed work that oftentimes primary cares won't do, to try to look at like root cause analysis, that sort of deal. So those are the 3 primary practice areas. We used to have dermatology and other spaces, but we're kind of recentering and refocusing on those 3 practice areas. So those will be the 3 that we'll offer in Coeur d'Alene.
Cool. Yeah,
nice.
I definitely want to come check it out once you guys get set up in there.
Absolutely.
Man, I appreciate it. That was a wealth of information. That was probably a lot for people out there. I feel like we could have you come back in a few months and do a round 2.
Yeah, I'd love to. It's hard to balance not getting too much into the weeds, because there's a lot of stuff that we didn't even talk about, and I try not to go too much into the scientific verbiage, that sort of deal, but at least provide some sort of framework to help people understand the space a little bit better, so they know what to expect in the space, and try to get a framework of what's real, what's not real, because there's just a lot of stuff out there that's hard to.
And Chris, I don't think we put you. We'll get them on the app.
Yeah,
we have an app now, North Idaho Experience. So, and we'll put it under regenerative medicine.
Yeah.
Okay. Pretty easy to find, but send me that information, so we'll have it on there. So anybody that does have our app, we have a whole list of people that we've obviously met and have some good information. And obviously now we're not affiliated with you either, but having you on here is great. So just giving people the opportunity to reach out to you. So we'll put that on the app so people can see your website, they can find your location, the phone number, everything else like that if they want to reach out. Yeah. We'll do that too.
Yeah, we talked about your app last when you were in the clinic like a couple weeks ago, and I think that's just a phenomenal idea. I love that. Yep. So I'd be honored to be on that space. And so I look forward to having you back out. We'll get you treated, and Seth, let me know when you're ready. We'll take a look at all your aches and pains.
I have a particular
better.
shoulder injury that's been nagging me for a bit, so I might have you look at that.
Can you do anything for his mood?
Stop it. I'm in a great mood. You're silly.
Get your shoulder feeling better and make it mood better.
Yeah, then I can choke Dave out again. Cool. Thank you, Chris. I much appreciate it, brother.
My pleasure. I appreciate what you guys are doing.
Yeah.
Cool.
Later.
Thank you.